Okay, I think we're ready. Okay. Good morning. My name is Andrew Evans. I'm from the Dutchess County Department of Behavior and Community Health. Our name has changed as we recently merged with mental hygiene. So we're under a new name, and it's actually, I have a hard time getting used to saying it myself. So I tend to, if I'm not thinking, I always say Department of Health. And I've been there like 27 years, so it's not going to change very quickly for me. So. All right, today I'm going to be talking to you about a topic you may be aware of already, but really it's a broad, just to give you some of what happened with the governor's plan to eliminate HIV in New York State. And I don't know how much you know about it, but I'm going to go through the plan today and tell you what's going on and, give you our perspective of what we're doing. So before I move any further, I want to introduce the real nuts and bolts, the real stars of the program that are here. I'm just the mouthpiece for them, is Michelle Eberling and Mary Angela Richard, both the public health advisors in the back of the room.
I think I changed your name. I apologize.
Okay, it's okay. It's all right. But Mary is in charge of does the Expanded Partner Services Program, which I'm going to outline for you what exactly that is, and you may be hearing from her related to patients. Michelle does our HIV Partner Services Program, and again, same kind of thing. You may be hearing from Michelle. And I also handed out a packet of information, a little packet here with their business cards as well to have their information. You guys want to say anything in particular to the group?
We are very proud to be part of our HIV team with Dutchess community members as well as local providers. My job is to relink people who are out of care, which Andrew's going to explain to you. We also do a little bit of everything. We dabble in the arts. We consider HIV an STD, so we work in our clinic. We relink people with care. If they have any questions about services, we'll be glad to help you with that. And Candace is one of our providers, which Andrew's going to introduce. And she takes care of the PrEP, or the Truvada, which also reduces transmission. So, anytime you need a hand, give us a call.
Okay. And the reason, Michelle, anything? Okay. The reason I introduced them fast is because of the clinic, they have to cut out a little early before we get going, before I'm going to be finished. So, all right. So the background about this, the whole plan here about the Expanded Partner Services is that in New York State in 2013, and our data doesn't, HIV data is usually always lagging behind. So this is an older slide, but in New York State, we had more persons living with HIV and AIDS than anywhere else in the country. So, that is sort of the backdrop for what they wanted to do here. 129,000 as of December 31st, 102,000 in New York City, and 27,000 in the remaining 57 counties upstate. What we have here is the real crux of the matter. In 2000, I was discussing this with Michelle in the hallway, 10 or 11, there was a law enacted where there was opt-out screening, where when someone entered the healthcare system, age 13 to 64, you had to offer them the option of HIV testing. Well, part of that law also came increased data sharing or increased sharing of information regarding HIV. And based on a lot of the data that was collected, they were able to devise a plan. And I'm going to explain this Cascade in a second. But it just really, what it was is that law opened up the ability for us to talk to each other as provider to provider about people with HIV. As you remember, the years before that, it was very cloak and dagger. If you had an HIV patient, it's basically in a locked box. You weren't allowed to talk about it, that kind of thing. And what they did is they eased up a lot of those stipulations. So what we have here is a New York State cascade of HIV care, and this is the crux of the matter, is that in New York State, they estimate that HIV-infected persons, about 129,000 people. That includes those people that are not yet diagnosed, and that's what part of that opt-out law was, looking to locate those people who did not know their status, because not everybody's going to volunteer and go get a test, but they might be, when they come in with something else, if you offer it, they might be interested in getting the test at that time. Then we know that of that amount, like I said, 112,000 or 87% of those people that we know are infected with HIV in the state. Now, cases of HIV that had at least saw a doctor for their HIV infection at least once, that's 86,000 within a year. That's 67% of them. Cases with continuous care, that means more than one visit to the doctor through the year, or a couple times, is about 58%. And then those that we know that are virally suppressed, that means that they're seeing the doctor, they're taking their medicine, and their viral load is undetectable, is only 55% of those infected. So as you see, there's a huge gap. We have a lot of people out there that are HIV infected that are not virally suppressed. And that's sort of the route where they came up, started thinking about this plan to eliminate HIV in New York State. This is the Mid-Hudson region. I don't have specifically for Dutchess County, but the Mid-Hudson region, again, very similar data. Ultimately, it's about 59% of people are virally suppressed. And the premise of why they're looking about how many people in the community are virally suppressed, when you think of vaccine-preventable diseases or you have a vaccine, you want to create like a herd immunity out there. The same basis is here. If the community, the wider community has, if we can get the virally suppressed, those people who are HIV positive, get greater than 95% of those people suppressed, then even though they're having sex, they're probably not transmitting the virus, so we're not going to get new infections. And that's the goal, the ultimate goal of this. And this graph here, I added this one to the talk. So, like, as you can see, it's like over time. Oh, and I have my fancy pointer here. Okay, over time, this is like the blue line is the number of people diagnosed with AIDS, and it, you know, in this area it went up. But then around this time, we got the drugs to help reduce the number of people who died or getting AIDS, and so the number of AIDS diagnoses went down, again, because the definition of AIDS, when you're virally suppressed, you're not at AIDS anymore, you're just at HIV infected. But as you see, new HIV infections began to be disproportionately become the most prevalent diagnosis. So we have a huge gap here between the amount of people with AIDS and the people dying of AIDS and the people with new HIV. The goal, the other goal of the governor's plan is to, you know, talking data, which I like numbers, is to get this orange line below the yellow line. And that has never happened in the history of the disease, to where the number of deaths are more than the number of people that are getting newly infected. And that's the premise of the plan. So the background of this is the National HIV/AIDS Strategy for the United States. What it is it's looking for a collaborative effort. I just need to look at my notes on this one, sorry. Almost there. Yes. It's President Obama's plan to combat HIV/AIDS in the United States. And what it is his goal is for reducing new HIV infections, increasing access to care for those people that are already HIV infected, reducing HIV health-related disparities in the community, and achieving a more coordinated response for HIV. And part of that plan is what we have, data to care. And part of this, what it is that data to care is a new public health strategy that aims to use HIV surveillance data to identify HIV diagnosed individuals not in care, link them to care, and support them as the HIV care continuum. And that there, so like, is the crux of what the new plan is. We actually got grant monies to support a position to do this particular activity. And what it is like we will get the, if within a certain time frame, we actually get They know the people that are HIV positive, and they detect whether they have a suppressed viral load or not. And if they do not, then we get that report, and we have to locate the person and link them to care. And this here is the three-pronged plan of the governor that put forth to reduce, to eliminate HIV in New York State. Number one is to identify all persons with HIV who remain undiagnosed and link them to health care. And that is, Michelle is in the back, that is one of her primary functions. She is looking for those people that do not know their status or are newly diagnosed. She's going to interview them, elicit their partners, and get them tested and treated. She's also going to link that new person to care as soon as she can. Number two, we've already discussed, this is the one that people that are diagnosed with to make sure that they are virally suppressed. And then the third prong of the plan is for those people, and I'm going to go into more detail, those people that are high risk for getting new HIV infection, to get them on pre-exposure prophylaxis so that they remain HIV negative. Because, I've been doing STDs, HIV for more than a lot of years, and basically, behavior change as far as STDs has been very rare to see. It's like it's still, people are still having unprotected sex at a very high level. So in some ways, if we can't get an HIV vaccine, like I said, the PrEP is a new little tool in the toolbox. Again, this is more of a local strategy, a local slide of the same thing, but just to tell you about HIV partner service, the traditional, what we've been doing, again, that law that I talked about, that opt-out testing law, is also part of that, is to find those people who don't know their status and get them, have them get tested and know their status. Then once they're reported HIV positive, like I said, Michelle will contact you, contact the patient. We conduct an extensive interview to find out who they've had sex or shared needles with, and then we locate all those people and get them tested for HIV. And the other aspect of it is that Michelle will also link that person to care. Again, Mary, who left the room, she's going to be linking and retaining persons diagnosed with HIV to make sure they maintain an undetectable viral load. So again, like I said, Ms. Mary's sort of looking what we call like previous old cases or old infections, and Michelle is more in the new realm. But we have a debate about what is new. If somebody's never been interviewed for partner services or HIV partner services, let's say somebody has had it for 10, 15 years, they may have never had that interview. If they're new to us, we are going to interview them because they could have a wife or a spouse that's never been told or identified as well. And we're also finding this definition of previously known positives or HIV positives in the newer, younger people. An 18-year-old who's had HIV for, gets it at 18, has it for 3 years, he's probably going to be very sexually active at 21. So it's probably worth re-interviewing somebody like that to see who he or she is having sex with or sharing needles with. Because they probably haven't settled down with that one person yet. So, again, there is the law that supports this as well, this data to care. All reports may be secured to the Department, Municipal Health Commissioner, or the District Health Officer under the provisions of this title shall be confidential except when used for purposes of patient linkage and retention and care. So that's the important thing, that the law is on our side. The law allows you to share the information with us and vice versa. I'm going to skip some of this. So again, like I said, what happens is for expanded partner services where we link the cares, they have a no CD4 or VL lab within 13 to 24 months. They go to the New York State surveillance system. They generate a case assignment, and for us, they're reported to the local health department, and that would be Mary. And then they call her a advocate, partner services advocate. And what she does is, like, she will work with that patient and with you, provider, link them to medical care, refer for identified supported services, do some risk reduction counseling, and do safer sex supplies as well. I'm going to skip that as well. Sorry. Okay. One of the things that Mary uses is a letter that is a pretty standard letter that you might see. The patient might even bring it with you as well. I think I also put a copy of that letter in here as well, so you can take a look at it. But just so you know that we do reach out to them in many different ways. One of the things that we can do is, like, to locate people, is we actually have something called Accurate. It's a search engine that can get very private details and find people that maybe moved to Georgia, that they're dead now, other things like that as well. So we have ways to find people that you cannot. So do call upon us to help you locate patients that are out of care. Okay, and I'm going to skip some of these things. Okay. The other arm of this plan is pre-exposure prophylaxis. It's very important. It's the daily Truvada, if you've heard of it. I'm going to take the opportunity now to introduce.
I'm Candace. So I work for Customer Healthcare, and we provide PrEP and PEP services. So we provide services from Columbia County all the way into Suffolk County. That's my area, and then we have Suffolk County on down there. So typically, our PrEP services are through referrals to the Department of Health, Hudson Valley Services, and doing community-based things where we go out to the community and do testing and do education, and then we have referrals that way. We also have referrals that we get from the local colleges. So typically how it happens is we get contact information from wherever our referral source is. I'm contacted and the patient has an appointment with us. Once they have an appointment with us, they become a patient of ours for PrEP services or PEP services. And I follow them through. They'll have an initial appointment where they will have a rapid or quick test, and then they will have a HIV 1 and 2 test, hepatitis panel, CDC, and typical blood work. For our MSNs, often the provider who is a infectious disease provider will do anal and oral swabs as well. After their initial appointment, which is inclusive of they're having an assessment with the provider and with myself as well. Depending on how the referral is, if the patient needs to be, if the patient is a test patient, post-exposure, and needs to be seen right away, I typically kind of do a telephone screening with them as I'm getting them in to see the doctor for PEP services, and then go into the PrEP services depending if it was a rape victim or just consensual unprotected. Another way is when they come in for the appointment and they're having an assessment with the provider, either before the provider goes in or after the provider goes in, I see them to give them kind of the follow-up education for what the provider has already told them, if I see them after the provider has seen them. If I see them before, I give them more in-detail education about the program. I give them time to think about if they're interested. I do a two-part assessment, like an initial screening that is basically demographic, and it asks about sexual history. The assessment goes more into sexual orientation, and it also assesses some mental health, things as well.
Thank you.
Substance abuse as well. Our substance abuse, part of the screening is, do you feel the need, or has anyone ever told you that you need to decrease your alcohol intake, or do you use drugs? Have you ever shared drugs? For our EMR, part of our EMR is a total social history. What we call our PQ 2 and 9, our mental health, based on depression. Then we have another section that's anxiety, and there's another section about smoking. How much do you smoke? How long have you been a smoker? Are you a chain smoker? And then underneath that is substance abuse. How often do you drink? How often do you drink more than 2 drinks? Are you drinking more than 2 drinks a week? Are you drinking 6 drinks, throughout the week? So it's pretty intense, it's pretty intense overall.
I came in late. I have a question. Entry point for these patients are what, HIV positivity?
There's 2 different entry points. For for somebody who's HIV positive, if they've never had HIV, if this is a brand new diagnosis, what will happen is you can call us, we can help you link them to care, like the Hudson River Health Care, for follow-up for their HIV evaluation. Then the other arm of it is at the health department level, we're going to do partner services for that person. We're going to find out who they're having sex or sharing needles with to find new and old infections of people that may have been exposed, and that's the entry point into this. As far as like the other entry point for expanded partner services is that those are people that are already HIV positive. How they enter into the system is that they have their viral load is not undetectable anymore, or their based on a CD4 count and a viral load count. We know that like they haven't been on their meds, and that's the other way that they enter the system. And they're both of them are reported to New York State Registry. Like for anybody who's any HIV screening or HIV test is positive, the laboratory, besides the provider, has to report it. Like, let's say you run the test on someone and they come up HIV positive, there is a form that you have to fill out and mail to the state. If you're not familiar with it, I have my information. It's on those cards. You can call and get those forms. The other way that we work with providers on this, especially since you may not have a lot of experience with HIV positive, is that Michelle, whose card you have, you can call her directly, and she can help you fill out the form and talk to the person, help you get that person into care, something you may not have a lot of experience with. So,
is this a local thing in Dutchess County, or is it run from the state?
It is. We do it in Dutchess County, but it's statewide. This program is all throughout the whole state.
Are you following them over time?
For HIV partner services, those are newly diagnosed. No, we do follow over time, and how it's followed over time is like when they get their blood work, if they have HIV, if their viral load is not undetectable, then it triggers something in the system to where it reports to us that we have to go find them and get them back into care to help, advocate to get them back into treatment so that we can suppress their viral load.
Here's my thought based on what I just heard. If we're targeting a specific illness, which is HIV in this particular case, I think it should be tracked. That should be really the concentration. Some of the items that you mentioned, smoking cessation, those are important, but then that diverts your efforts into something else, and that might be problematic in terms of presenting multiple pieces of information to a person that might just do better with one item, which is HIV, not to have other partners, to bring all the partners into care and diagnosis if they do or do not have. So this is my
Well, my piece is the PrEP education piece part of it. So as far as the social history, and that's usually taken by another nurse when the patient enters, and if they're in the patient of ours. I typically just specifically go over PrEP and PEP information with them. And again, we do have, part of our assessment is to, hear substance abuse, is there mental health issues, is their sexual attitude or behavior, is it because there's some mental health issues that if those mental health issues may be addressed, maybe they would be at such of a high sexual risk. So that's why we kind of do that part of it too.
Question, how are you interacting with the original doctor?
With the provider that's there.
The original doctor that sent the patient.
Well, typically they're not coming from a primary care. Typically they're being referred from the Department of Health or Hudson Valley Services, and then they're referred to me from Hudson Valley Services or the Department of Health. They're typically not coming in from primary care.
I see a problem in that particular model itself. At the very essence, it should be primary care. I'm a primary care doctor. So I'll see a patient referred to you, and then sort of it gets lost into a few.
Well, I do get consent. That's one of the first, I do get consent from the patient for their primary care provider if they have one, so that we're able to share information.
But I think the primary care person should be taking on a lot of the responsibility.
Absolutely, and that's one thing as well. Right now, the issue is trying to even get our primary care providers in providing PrEP to patients, because I think that, you know, a primary care doctor that's a patient, we're only seeing them for PrEP, so there is a lot that could be missed. So that's an issue with primary care doing PrEP. So far, out of our providers, we have 5 primary care providers who are prescribing PrEP, and that's literally just been in the past 4 months. So that's a struggle.
These are primary care from your particular department, not from the primary care person on the periphery that's seeing the patient that's their doctor.
Well, that's, I think, overall. I went to a conference in Albany, and it's been overall an issue with getting primary care involved. So that's why it seems, you know, that we're doing.
I think that's why we're having, what you're bringing up is why we're having the conversation, you know, from the health.
Sorry, I'm infectious disease. A lot of primary care doctors are not aware of it and are not familiar with the things that it meant. So sometimes they refer them to us too. So it's a matter of education, and it's not hard to do.
No.
Correct.
No.
It's a matter of educating, reading.
And that's where I was, actually, I'm headed into PrEP. We'll talk about that in more detail. But yeah, what you bring up a very good point, and that's one of the reasons I'm here, is to start having the dialogue about this, because, you know, Hudson River Healthcare has been one of the leaders in stepping up and starting to do PrEP. But like, I would like to, it's like you said, it's actually not for you guys. For me it is, but for you guys, it's not terribly difficult to monitor a patient who wants to be on PrEP or who has HIV. You don't always have to refer them to an infectious disease specialist, as you're saying. It's like, and that's, like I said, I'm here to start that kind of dialogue.
It's my point. Somebody should take the lead in terms of being the primary care doctor, whether it's Nellie, the infectious disease specialist, or myself. Some of us should be totally involved in the care of the patient. And then, of course, the state should be tracking other partners and things that we're not going to know about.
Right.
Whether or not we actually need to know about it might or might not be important in terms of the management of the patient.
Yeah. No, we would help you with management of patient. Anything with partners, we're not allowed to share that with you unless there's a real medical reason to do so. But we do not link partners. The only time that you, as far as for HIV, that primary providers involved with a partner or a notification of a partner is in the case that, like, you have 2 patients and patient X is married to patient Y, patient X is HIV positive. By law, you are required to notify patient Y. But you could talk to patient X first and say, I have to tell your wife about that she's exposed to HIV. You don't tell them who, what, where, how, when. You have an obligation to do that. But if you don't wish to do it, you can call us and we can do it for you. So that might help protect some of the anonymity. But but that's the only time you get involved in actual direct partner services. So, but what you, like I said, you bring up a very good point. As like I said, it's just, like you said, it's just, we need to. This is sort of, some of this is in its infancy, and we're trying to, like, get the word out to get you guys on board. That's why I'm doing this for OBs and the pediatric group as well. So we want to get.
It just came about 2 years ago, right?
Yeah, it's just starting, and like I said, and so like it takes a while to everybody gets on board, and everybody starts to show it, to understand what it is, how it works, how it fits into what you already do. And I know you guys are have an awesome amount of tasks that you try to do every day. So, and again, we are here, and also Hudson River Healthcare as well, but we are here to help answer your questions, guide you, give you resources if you need to want to get involved. But as far as pre-exposure prophylaxis, there is guidance, CDC guidance, and there's 2 big books on it to help you. They're very detailed about how to do PrEP. And PrEP, that is like number 3 on the plan. And the reason why we're targeting this is like we're seeing major increases in other STDs. So there's a lot of sexual activity going on out there. We're finding that people are not changing their behavior. They're not wearing condoms. They're actually not afraid of HIV anymore, unfortunately, because they're not seeing it like it used to be. They've lived with it. So what it is like persons that are high risk that aren't going to change their behavior, we have this new tool now called PrEP, pre-exposure prophylaxis, where they take Truvada, daily Truvada, and it makes it so that it protects them from getting HIV. Now, on the flip side of that, it's like, because I went to a New York City thing for a day that talked about this, and there was a room full of providers. It was very interesting how divided the providers were about this, because some do not feel comfortable prescribing antiretrovirals to somebody who's perfectly healthy, where others saw it as like them taking birth control. They're not going to change their behavior, so at least if they're not going to change their behavior, at least they're not going to get HIV. So it is a battle. A term they use for this in the private community is something called a Truvada whore. They think that because they're taking this medicine, it gives them the right to just go out and screw around the way they wish to. But I look at it this way. I'm working with sexually transmitted diseases since I started my career. This problems with this came since the mid-'80s when I started to now. It's like people don't wear condoms, people aren't responsible, and it just, like I said, the behavior changes needed for this are not happening. So you almost need almost something like this or a vaccine to actually really reduce the spread. And that's what I just wanted to hammer home here. It's like, over the years, we get about 50,000 new cases of HIV in the United States each year. So it's been pretty steady. But if you look behind the numbers, there are increases in certain populations. And in adolescents, like for HIV, men who have sex with men, adolescents, we're seeing a stark increase in HIV and new HIV infections in that population. And again, here it just hammers home with estimated new HIV infection in the United States in 2010. It was, like I said, the top 3 are men who have sex with men. Again, a part of it is and I'll put up this phone, their sex-seeking behavior is now gone on to here. They have apps where okay, I'm in the mood now, so I go on there and there's a guy 200 feet away and we'll just go to the bathroom and get it on kind of thing. And this has created a exponential, almost there's a very good film that looks at this called Gay Sex in the 70s. It was before AIDS. And this is sort of that, but it's on a larger scale because now because of this, people create almost a pornographic profile themselves. They can get involved because they don't have to take a shower, get dressed, and go talk to someone. They can actually do it more anonymously. So more people are participating in the activity as well. So again, I just wanted to show you too is I put high-risk heterosexual sex up there as well. I don't want to just focus on men who have sex with men. There are other people that are high risk that would benefit from having the PrEP, the daily PrEP, and that would be determined by you guys as well. Because if you make a determination that the person's high risk, then the insurance will cover the PrEP. In most cases, that's correct.
If they don't have insurance, there are a few programs. There's the ADAP, which is usually for HIV, but there's the ADAP for PrEP. And if they are one of our patients, I handle everything with the insurance. And then there's advancing access, which is through Gilead. And if the patient has insurance and their copays are high, Gilead even has a copay card, which I just register for the patient, call into the pharmacy, and typically they have a zero copay at that point. If it's someone who is on their parents' insurance, the visit, we can bill it a certain way where they don't have to worry about the EOB going back to the parents, especially the college students, but they would have to use the insurance for the prescription.
Thank you for that. So yeah, so there are ways that a lot of people can access. The New York State has a registry of providers on their site, that are PrEP providers that you can refer to. But again, like we had the discussion, I think I would like to see more of you doing this for your patients instead of referring them out, because you can do it for your patients. And like I said, the CDC has very good guidance for how to manage patients.
And I have some copies here.
Okay.
So we do mostly inpatient. I don't have someone to go to the office work. So, and our problem is for patients who don't have insurance trying to get to the IV doctor or getting medication, but getting medication and they're expensive. So how do we put them up to?
Like I said, call us and we can work with an agency like Hudson River Healthcare, which is expert in helping people with these kinds of issues of cost and getting access to medicine and care.
I'll leave my information here, and like I said, if they're referred to us for PrEP, once they're referred to us, I pretty much, once they see the provider, I pretty much walk them through everything. I schedule all their appointments, their follow-ups, I follow them the whole way. Any insurance issues, I usually address it. Then in there, again, there's Gilead, who has 2 different programs, which is a patient assistance program, and then the Advancing Access, which will pay for medication. The PrEP app, which is the ADAP for PrEP, will pay for services. And then if there's a patient, again, who has insurance, let's say their copay is like $300, then Gilead has a separate, it's a copay card. And typically they have a zero balance. And then there's other little companies in between. So either way, they'll be, there won't be an issue with them, accessing the medication, even if they're undocumented.
I think my best, to reach out to case management because they're the ones who actually,
Yep. There you go.
Set up, so, if they're informed, at least, that way,
Okay.
Yeah.
we know what to do with our patients, yeah.
Right. And then, like I said, you can contact us.
Yeah,
Can't.
anyway, you have ADAP.
Yeah.
And I don't know if everybody knows that.
No, the case manager should know, but ADAP has been there long time.
Yeah. And the ADAP they applied it to PrEP.
Yeah, and I have a few patients that have been pretty good. They haven't had any issues with billing or if they're covered 100% of their business.
It sounds to me that there are glitches attached to this whole situation. First, the healthcare field now is cross-section. So you have a hospitalist that sees the patient, then a primary care person that sees the patient. And the connection is not really there. There isn't this longitudinal care. The other factor that I'm seeing that's a real problem is insurance getting involved in the middle of all of this, and you have to go through a third party now to deal with an epidemic that seems to have been controlled in the United States. When I started in this, we didn't know whether or not this epidemic would balloon out to something that we couldn't control.
Right.
But at this point, 30 years later, I'm seeing this tremendous gap in terms of what I think can be done and what is actually being done. And some of it has to do with bureaucratic, having to go through an insurance company, not having a provider that's there alongside the state in terms of managing the patient. I think it's a real problem based on what I'm hearing today.
And I'm sure there are things like you describe. And again, I think what we go back to, I think what you're bringing up is getting more of you involved in this process, I think would benefit the patient. I think, like I said, this is limited people. Again, like you said, I think you guys are the only 5 providers that that are registered to get PrEP, that are doing it, that we know about. And I'd like to see more. Like I said, to have the patient be able to go to their own doctor and get it instead of having to come. I'm not saying they shouldn't come. Yeah, because that's what it would be. That would make it more let's say I wanted to go on it. I'd be more comfortable going through my own doctor and having him manage me than me going somewhere else for this, because of it. It can be embarrassing. At least you've already dealt with a lot of other issues as well. So I'd like to say you bring up a lot of really good feedback, and this what you bring helps me come up with a plan of how to go about this, because this is my first foray into coming out and talking about this, because I want to get the information out to you guys, and then we could start having dialogue and come up with something that can be effective and work. So, and get your feedback on what's happening. Yes?
The reason I asked for to discuss this with you is that, we are seeing an uptick
regard to complications with opioid and in with regard to, I'm curious as to what the numbers are within that sector of our local population in regard to HIV.
We're beginning to see, like I said, that's why like this slide here, you help me bridge back to here. Like, I want you to not, because we always, right now we hear men who affect the men.
Yeah.
But like, we're beginning to start, it's starting, it's not in full force yet. We're starting to see these effects jump into other groups. And the heroin addicted are one of the groups that it's starting to find its way into.
Yeah, in Illinois, HIV epidemic in Indiana, there was a big the whole or whatever.
And like I said, these are the beginning steps. And once it becomes entrenched into that group, it'll grow like the young MSMs are.
And the HIV is also driven by suburban kids who are abusing drugs and it's driving up HIV and Hep C. That's the other problem.
And we're seeing other STDs in this population as well. And that's
Hep C is becoming a big problem.
And that's like, and Hep C, but like see this here, this one here, not one that we often talk about. That is the most reported infection of the reportable diseases in the United States, chlamydia. And the targets young people, opiates, of what you're talking about. And females, like 4-to-1 or female ratio as far as becoming infected. Because that, just so you know, there are other people at risk, not just MSM. And I try to get off, you need to know about the MSM, it's very important, but IDUs and high-risk heterosexuals, they also would benefit from being on Truvada. Because again, wouldn't it be nice if we could nip it in the bud before it becomes entrenched in these other populations? Again, as the health department, we're on the front line, so I'm beginning to see it happening, but like I said, it hasn't reached the large numbers yet, thus it's not become newsworthy. But I can just tell you that it's starting to happen, the dynamic is there. And once these infections find themselves into these groups of people, then it starts to explode. You know, if I came back in a couple of years, we'd start seeing a graph of something different. So. Again, like I said, this is a recent slide that I just wanted to show you, is that we're in New York State from 2010 to 2014. It's the first time we've actually seen an increase in all 3 of the major STDs. And so just so you know that, like, it's not just gay men that are getting these STDs. And that is it. Do you have any other questions? I definitely appreciate all of your feedback. This really helps. So, all right. And like I said, we have our